So thank you very much, all three speakers, for your very inspiring talks. We will start the roundtable discussion now. So the first question from the floor, I think that's directed to Andrew. The audience would like to know, are there actually longer term data on weight changes for patients on dolutegravir and efavirenz?
So there's very little data, unfortunately. Advance has the largest data set out to 2 years and probably to 3 years. My understanding is that there will be longer term follow-up of that study out to hopefully 5 years. There aren't other studies of that duration in antiretroviral naive adults. The longest switch study is 96 weeks, and likewise the longest PrEP study is 96 weeks. So we have unfortunately no idea whether the changes we're seeing in weight out at 2 and 3 years will stabilize or not.
Yeah. So let's wait for longer term data from the larger cohorts. And the second question, I guess maybe Andrew and Catriona may like to comment. So Andrew did present on some data in pregnant women taking a TAF and TDF and the impact on the weight changes. So how can we tease out the effect of these drugs in pregnant women on weight and also the hormonal effects during pregnancy? So would there be any interaction between the hormonal changes and the drugs that they are taking, and that would impact on the weight changes?
Personally, I don't know the answer to that. If the data that were presented earlier this year on from the impact study suggested that TAF dolutegravir gave similar changes to those observed in the general population. If there was an impact of something like hormones or drug exposure that was affecting weight, then the fact that they're the same as the general population would mean that there must be two factors, one making things worse and the other making things better, which that's a complicated explanation, and I always prefer the simple one. So my simple interpretation is, at least in that population, that the drugs are neutral.
And I would come in and say that one of the advantages with the Dolphin 1 and Dolphin 2 studies is that they were randomized. So we're randomized to either efavirenz, which was standard of care then, or dolutegravir-based regimens. And then we have quite an extended follow-up. However, with transition of national policy to dolutegravir, suddenly it becomes much more cloudy. But we have incorporated an extended mother-infant pair follow-up into that design. But as you've mentioned, and as the question, I think, has emphasized, this is so complex. And I think the bottom line is it underpins the need to do the studies in the populations who are actually going to get the drugs and to factor in that longer term follow-up, which is so difficult in a clinical trial setting.
Yeah. Just following on these weight gain issues. So Andrew, you did mention about the outliers in these studies. So there seems to be a subpopulation of patients who do have quite significant weight gain. So you mentioned some of the risk factors that were observed from the study. So from your own experience, do you identify any patient characteristics that we should be more alert, that they are more prone to very significant weight gain?
So I think there's two things to be alert for, right? One is who gets the most weight gain, but also who gets the greatest effect from that weight gain, right? Mm-hmm. So yes, to answer the first part of your question, I don't unfortunately know which of my patients are going to get the most weight gain. And they all ask me is what's going to happen to me in the next 1 or 3 years. And unfortunately, I just have to tell them that I don't know. And although we do have some risk factor data in antiretroviral naive adults, that's very diluted by the return to health. So I would much rather see analyses like that in switch settings and where you're only looking at one drug being switched. So at the moment, we don't really have that type of analysis. The second thing is a 5 kilogram weight gain in a 30-year-old person who is lean and doesn't have underlying health issues is very different to a similar weight gain in a 60-year-old who has high cardiovascular risk or who is pre-diabetic. So I think it's not every weight gain matters the same amount depending on the individual. I think my younger patients are much more concerned about the cosmetic impact, understandably, and my older patients are much more concerned about the health impacts.
Yeah. So personalized medicine is actually very important in our field. So Catriona, so you in the first part of your talk, you mentioned about the ethical principles in doing studies in pregnant ladies. And so you did mention that there's often a delay in data in pregnancy after a certain new antiretroviral drug is being licensed. So actually, do you have any recommendations? So should we actually wait for more data when we start a new drug in a pregnant lady, or we just try when there are actually limited options sometimes?
So it is difficult, and Angela Kolbers and colleagues did publish a beautiful paper in CID in 2019 that showed that the median time from licensing to actually having meaningful data for ARVs was 6 years. And in fact, for lactation, it was more like 8 years. And actually, antiretrovirals are a lot better than other classes of drug. I think we have to weigh up risks and benefits according to the information we have as clinicians. And so if there is a drug that we know works and is likely to work in that population and there's evidence, then that obviously would be the one we start with. Of course, occasionally we end up in situations where we're having to use drugs perhaps in salvage situations or complex resistance patterns where we're not working in an ideal world. And there, I suppose we should just make our best judgment on a case-by-case basis. But in general, I would prefer to use an agent that I knew to be safe and effective and have that pregnancy data. So I could really reassure my patient as well, because if we want to bring the patient into a shared model of care, it's quite important we can give them that information too. I don't know if you feel differently in your clinical practice or if there are some scenarios where you've had to use drugs with less information than you want.
Yeah, well, I think the story of dolutegravir, for example, when initially there were some concerns of safety, I think in scenarios like that, we might be quite difficult in recommending for or against a certain drug while we are waiting for more data.
And the dolutegravir story is actually, I mean, it could warrant a whole talk in its own right, and I focused on late pregnancy. But absolutely, we had the Botswana situation where they moved to using the drug. Then there was a potential signal about neurotube defect. Then there was an alert from the WHO. Then there was an outcry from the patient groups. Then finally, there was more data, and we decided it was actually okay after all. But it's caused a huge amount of confusion amongst the communities we work with. And I think there are many lessons that can be learned there, yes.
Yeah, definitely. So Madeline, thanks very much for your very inspiring talk on transgender patients. So there's a question focusing in resource-limited countries where hormonal therapy and antiretroviral drugs for transgender people, especially the interaction between the two kind of therapies, actually don't have much research. And so how do you think the clinicians can help the transgender patients understand that antiretroviral therapy is actually not an obstacle to the gender identity issues?
Thank you very much. Yeah, I think that is really the core question that comes up. And I think there's a second question in there that this may be getting to both of them, which is, it is absolutely correct that we have a significant lack of research in this area on these interactions. But what we generally don't have any data from other fields, like from pregnancy and contraception data, that would make us think that there's a significant interaction with hormone therapy and any antiretroviral in a way that hormones have a negative effect on the antiretroviral therapy. So most people working in my field are generally unconcerned with the existing classes of antiretrovirals and a negative interaction occurring as a result of hormone therapy on the antiretroviral activity. The big issue that comes up is a perception that there will be a negative impact on the hormone therapy from the antiretrovirals. And I think that that is really the steep ladder that clinicians will need to climb in order to link into care and then retain in care and maintain good adherence among transgender women. And so a lot of that work involves engaging with local community leaders and trying to do a lot of community-based work to get messaging out, social marketing and other efforts to kind of get the message out. It is an uphill battle, though, because in my country, we're dealing with a lot of kind of anti-scientific outlook in general. And so there can be a lot of mistrust of the medical institution, especially if you're a transgender person living in a society where there's a great deal of structural bias, then you may identify the medical system as being part of that structure that is biased against you. So it does require a lot of both community level messaging as well as building a one-on-one trusting relationship with the individual patient.
Yeah, certainly. So I think maybe the last round of question I would like to ask more on the antiretroviral therapy. So for Andrew, you did mention about the option of switching antiretroviral therapy in patients who do have quite significant weight gain issues, and also maybe the impact of weight gain that you've just mentioned. So any particular drugs that you would switch away from or you would switch to, since there's actually not much data?
It's the obvious question, and one you could see I tried to avoid in my presentation, right? Because we don't have.
I'm sorry, I'm asking you this.
No. I think it's a great question to ask, right? So, for patients who have spent a reasonable period of time trying to address their weight, or those people who are very confident that their weight and exercise routine has not changed, and yet they have gained a substantial amount of weight, then they will always ask, "What should I do?" And at the moment, we're faced with a potential contribution from at least one nucleoside, TAF, and a contribution from the integrase class, and maybe dolutegravir and bictegravir have more of a contribution than some of the others. So if they are very desperate to change, then I will need to construct a regimen based by removing both of those, right? So, and there are multiple options. For most patients nowadays, there's not a lot of background resistance in the patient population that I treat. So there's usually, whether that's a protease inhibitor or a non-nucleoside, other nucleosides. I have done various switches depending on the individual. What we need, of course, are the randomized trials. There's at least, there are a few randomized trials underway or planned, but I don't think we'll see any substantial data for another 9 to 12 months.
Yeah, okay. So, Catriona, so for breastfeeding, so mothers who are breastfeeding and who do choose to breastfeed and while taking antiretroviral therapy, any recommendation on the choice of drugs, particular regimens we have to avoid, or any preferred regimens?
And again, that is actually an extremely good question. And I often get asked, and I feel like people are wanting me to almost say this regimen is better. But the regimen that is best for a breastfeeding mother is the regimen that suppresses her viral load and that she can adhere to. Because whilst most of the drugs, except the protease inhibitors, they do get into the breast milk, they can be measured. They do get into the baby and can be measured, but they don't seem to cause any harm, with the exception of the very, very rare cases when a transmission occurs. So my broad principle is whatever she takes that she can adhere to, adherence is far more important than any particular differences between regimens.
Yeah, that's very true. So the last question for Madeline. In terms of the antiretroviral therapy, you mentioned about the drug levels like tenofovir using the dry blood spot in the PrEP trial. So do you think in clinical practice, in transgender people taking both hormones and antiretroviral therapy, does therapeutic drug monitoring, is there any role in clinical practice?
Therapeutic monitoring of antiretroviral levels.
Yeah.
That is difficult. That's a technically limiting issue. Monitoring antiretroviral levels in real time to provide real-time feedback on, and adjusting of clinical care is complicated. Even in our study environment, and we actually looked at doing this as part of our study, and it's fairly complicated to do that. So it's probably not a likely answer at least in the transgender medicine world, and in general, kind of real-time monitoring of antiretrovirals. Probably not a high value, high yield. It's also very resource intensive, and I just don't think it's broadly applicable. I think that the take home that I would say, just kind of reiterate what I mentioned in the talk, is, some of the data that we've seen suggests there could be a very limited impact in a PrEP context. I don't really know that necessarily translates clinically to the treatment of HIV. And even in the PrEP context, nobody is really that concerned that PrEP is not going to be effective in transgender people. We just might want to be a little more intentional about things like episodic PrEP, where you have to be a little bit more reliant on exacting levels. So I guess the short answer is probably not the answer to actually follow drug levels, probably not feasible, and also probably not likely to be very high yield, probably not going to have a big clinical impact on decision making.
Okay. So Catriona, so you are the only clinical pharmacist here. So any comments from you on drug monitoring, both maybe in pregnancy situations and also in people who might have drug interactions issues?
So I think therapeutic drug monitoring for adherence, it's actually something we do in-house here in Uganda for some of the drugs, simply in a quite binary way. Is their drug measurable or not? Because obviously if there's no drug, we know they're not taking it. So we do use it in quite a crude way. And I think that's a situation where it can be useful, because sometimes you can then kind of confront the patient, or confront is the wrong word, show the patient your result. And then often they do then start to open up about their problems. So that's where we would use it. But routinely, it can be complex, I think.
Yeah. Okay, so thank you very much, all three speakers. I'm sure the audience would agree with me that we did have a very wonderful time and we learned a lot from all three of you. So with this, we are coming to the end of the first day of our program. And okay, so we value your feedback, and please fill out the session survey at the end of the session and participate in the post-workshop survey after the event. And a certificate of attendance will be sent to you by email after completing the post-workshop survey. Next slide, please. So we will welcome you back tomorrow, and we will have very fascinating talks from distinguished speakers for the whole day. Next slide, please. So thank you very much for joining us today, and see you all tomorrow. Bye-bye.